So we're going to start off with a bang and hit bone signaling and rank ligand, one of my favorite topics. So question number 36. Rank ligand is an important regulator of bone resorption. What cell expresses rank ligand? So you got to know the rank ligand OPG pathway. If you know this, rank ligand is expressed on osteoblasts. The rank receptor is what's located on an osteoclast precursor cell. Osteoprotegrin, this OPG, is the osteoblast is a secreted by the osteoblast and is a decoy receptor for rank. The key here is that cancer cells aren't directly responsible for tumor-induced osteolysis. What they do is they activate this pathway, causing osteoclasts to resorb the bone. So if you look at this little cartoon here, you have your osteoblast. Let me get a pointer here. Osteoblast down here secreting rank ligand to act on the osteoclast precursor, causing osteoclastogenesis and bone resorption. OPG, also secreted by the osteoblast, blocks this rank ligand's effect to block osteoclast precursor activation. So if we go back to the question, rank ligand is an important regulator of bone resorption. What cell expresses rank ligand? Well, it's number 2, the osteoblast. It looks like 90% of you guys got that right, so that's awesome. One thing that's coming down the pipeline in tumor surgery is this new medical therapy called denosumab. You might see this in the next couple years, so we'll just spend a second on it. Again, similar cartoon, osteoblasts secrete these little nuggets, the rank ligand, which activate the rank receptor on osteoclasts, causing bone resorption. Denosumab is a monoclonal antibody directed against rank ligand. So here you see the little Y, that's the universal symbol for an antibody. And what this denosumab does is it sequesters the rank ligand, blocking its interaction at the rank receptor and blocking osteoclastogenesis. Next question, 46. Calcitonin plays a role in bone metabolism by which of the following mechanisms? To get this question right, you need to know a little bit about the cell signaling of calcitonin on the osteoclasts. So calcitonin actually inhibits osteoclastic bone resorption by directly binding the cell surface receptor, the calcitonin receptor seen here. What it does is it decreases the osteoclast number and activity. So after it binds to the calcitonin receptor, it decreases the resorption through an intracellular signaling cascade. You don't need to worry about pKa, pKc. Those aren't going to show up. Those are very common intracellular signaling molecules, but not important for our testing purposes. In addition to downregulating the resorption, what calcitonin also does is it decreases the gene expression of the calcitonin receptor, seen here in italics. So it's a negative feedback loop. Calcitonin binds to the receptor, decreases resorption, and also decreases its gene product. Going back to the question, calcitonin plays a role in bone metabolism by which of the following mechanisms? Well, the correct answer is 1. Looks like 72% of you guys got that right. That's awesome. If we look at the incorrect answers, number 2, calcitonin does not function through the rank ligand pathway. It binds via the specific calcitonin receptor. Number 3, calcitonin actually increases OPG production in the osteoblast, again inhibiting osteoclastogenesis. Number 4, calcitonin actually opposes the effects of parathyroid hormone. And number 5, calcitonin decreases osteoclast activity. So remember your O's, calcitonin with an O, opposes with an O, bone with an O, resorption with an O. Calcitonin opposes bone resorption. Next topic, immunology, one of my favorites. Question 10, the acquired immune response mediated by the interaction between the T cell receptor and the major histocompatibility complex requires which of the following steps? This is orthopedic minutia if I've ever seen it. But you got to know a little bit about immunology. There are 2 types of immune responses, the innate immune response and the acquired. The innate immune response is found in all life forms. We have almost the same innate immune response as the slug. It's nonspecific, it carries no memory, and some examples are your skin, the complement cascade, or generalized inflammation. The other kind is acquired immune response. This is antigen specific, so it has a memory. It requires antigens to be processed and presented by antigen presenting cells, 2 examples of which are B cells and dendritic cells. What these antigen presenting cells do is they break down the antigen, by enzymatic reactions and actually put it on the cell surface receptor of the MHC complex to tickle those T cells in just the right way, causing their activation. So in addition to these two general types of immune response, you have to know your types 1 through 4 immunological reactions. Type 1, the anaphylaxis, 2, antibody-dependent, 3, immune complex, and 4, delayed type hypersensitivity. Going back to the question, the acquired immune response mediated by the interaction between the T cell receptor and the MHC complex requires which of the following first steps? Again, you guys are doing great on this. 88% of you got this answer correct. It's 2. It requires antigen processing and presentation to T cells. The APC grabs that antigen, chops it up into little short peptides, and then presents it on the cell surface MHC receptor to tickle the T cells. Since you guys got most of this right, it looks like answer 3. So this is the tricky one in this. Natural killer T cells are actually involved in a little bit in autoimmunity and cancer immunogenesis. The difference between NKT cells and regular antigen-presenting cells is that NKT cells actually present lipid or glycolipid antigens, so very specific, and they are associated with the CD1A receptor. So it's a little bit different than the MHC receptor, but a similar concept. Next topic, rheumatoids. So which immunoglobulin subtype does the rheumatoid factor target? The rheumatoid factor is an autoantibody most commonly seen in rheumatoid arthritis, but it can also be a marker of generalized autoimmune activity unrelated to rheumatoid. It's an IgM antibody directed against the IgG antibody. So remember your differences when you're trying to study for the exam. IgM is the only antibody that's a pentamer. All the others are monomers. So IgM, you see all of these monomers jacked up in a pentamer by this joining chain. And what happens is the rheumatoid factor, an IgM antibody, attaches to the IgG, forming immune complexes that are then deposited in the end organ tissues, causing problems. Back to the question, which immunoglobulin subtype does the rheumatoid factor target? Well, the correct answer is 4, IgG. So it looks like we had a little bit of trouble on this. So let's go over the incorrect answers. Number 1, IgA. This is a secreted antibody. It's found on mucosal surfaces. It's found in breast milk. So it gives a little bit of passive immunity to feed it to newborn children. IgE is involved in allergy and in some parasitic infections. IgM is the monomer versus the pentamer of the rheumatoid factor. Rheumatoid factor does not target an immunoglobulin. Well, this is incorrect. We know this to be the case. One little nugget of information is that IgG is the only antibody which can cross the placenta, giving passive immunity to the fetus. Next topic, psoriatic arthritis. 47-year-old man complains of long-standing pain involving the right index, middle, and ring fingers. Clinical images shown, radiographs is provided. Which of the following is the most likely diagnosis? To get this question, you have to be able to recognize psoriatic arthritis. So this is a seronegative spondyloarthropathy that affects about 5 to 20% of patients with psoriasis. Remember your HLA-B27. It's found in 50% of these patients. This equally affects men and women. So some of the manifestations, you can get this sausage digits or the nail pitting or the chronic uveitis. Remember to refer these patients to ophtho. With respect to these sausage digits, don't let these patients go into careers in proctology. They're not going to make good proctologists. Looking at the treatment, you can either treat them non-operatively or operatively. The non-operative is generalized immune surveillance with NSAIDs, methotrexate, cyclosporin, TNF-alpha inhibitors. The operative interventions include digital fusion or resection arthroplasty. Going back to the question, we see nail pitting. It's kind of hard to see in this small image. I hope you could see it on your exam. You see the big sausage digit. You see the pencil in the cup deformity. 90% of you guys got this right, psoriatic arthritis. Nice job. Next topic, intervertebral discs. Recent studies have shown that cells of the intervertebral disc are biologically responsive and increase their production of MMPs, nitric oxide, IL-6, and prostaglandin E2 when stimulated by what molecule? Again, OITE minutia. What do you need to know to get this question right? You got to know spine and cytokines, two of the worst topics on the face of the earth. So herniated discs are associated with a spontaneous increase in the production of OPG, interleukin-1 beta, rank ligand, and parathyroid hormone. So going back to the question 2, recent studies, biologically responsive intervertebral discs, they increase their production of MMPs, nitric oxide. But what's the correct answer? Well, it's interleukin-1 beta. Again, this is a hard one, but you guys did really well, 62%. That's awesome. So 30% of you chose answer 3, TGF-beta. A good choice on the exam if you're guessing. A lot of things are downstream of TGF-beta. In this case, however, TGF-beta is an anti-proliferative factor and involved more in oncogenesis, not necessarily in the intervertebral disc anatomy. Anti-inflammatory medicines. Question 18. Arachidonic acid is directly metabolized by which of the following substances? This is a must-know. You should commit this to memory. Prostaglandin synthesis, inhibited by your COX enzymes. COX catalyzes the formation of prostaglandins and thromboxane from arachidonic acid. COX-1 generates prostaglandins responsible for the maintenance and protection of your GI tract. And COX-2 generates the prostaglandins responsible for inflammation and pain. So if we go back to the question, question 18, arachidonic acid is directly metabolized by which of the following substances? Correct answer is 4, cyclooxygenase. You guys did really well, 78%. Looks like the other answers were a little bit spread across the board. Maybe this is just one to commit to memory. Remember that phospholipid bilayer that the phospholipase digests, creating these free arachidonic acids. Then you generate the prostaglandins by the COX enzymes. Next topic, embryology. Question 27. What is the function of a homeobox gene products? A little bit about embryology is always something good to know for your exam. There's usually going to be at least one question on it. Got to know your limb bud growth. If you go proximal to distal, you're looking at this apical ectodermal ridge, the AER, that's controlled by fibroblast growth factors. Dorsal to ventral growth is controlled by the Wnt genes. Anterior to posterior growth, looking at your sonic hedgehog genes. The ZPA, the zone of polarizing activity, plays a role in the digit formation. So a lot of three-letter short acronyms, something just to commit to memory. If you look at the gene functions and interactions, the sonic hedgehog genes lead to the expression of the Hox genes, the homeobox genes. These Hox genes are important for regulating somatization of the axial skeleton. Going back to the question, what is the function of the homeobox genes? The correct answer is 2. They regulate somatization of the axial skeleton. Again, you guys did really well on this, 74%. Let's look at answer 5. They mediate the activity of the polarizing zone. This is a tough one. The zone of polarizing activity and the apical ectodermal ridge are actually involved in limb bud development, but not somatization. So it's a minor difference, but an important one to remember for your exam. Next topic, bone cells. Cathepsin K is an enzyme produced by osteoclasts. What's the function of cathepsin K? Osteoclasts, my favorite cell. They're multinucleated giant cells that resorb bone. They have this ruffled brush border that increases the surface area for resorption. And they resorb bone by this tartart-resistant acid phosphatase. Cathepsin K is one of the enzymes produced and released by the osteoclasts at the ruffled border to function to resorb bone. Currently, cathepsin K inhibitors are being evaluated as potential anti-resorption drugs used for osteoporosis. Back to the question. Cathepsin K is an enzyme produced by osteoclasts. What's the function of cathepsin K? Well, it's 2. It's involved in bone resorption. 66% of you got that right. Let's look at answer 1. Reduction of disulfide bonds in the extracellular matrix. Again, a tricky one. So these are actually the GILT enzymes, G-I-L-T, it's an acronym. GILT enzymes, probably not too important to remember, but GILT enzymes are involved in generalized antigen processing. So when a protein antigen comes into the cell, the GILT enzymes cleave the disulfide bond to unwind the enzyme and allow further antigen processing. So that's the difference. GILT enzymes, G-I-L-T, reduce disulfide bonds. Next topic, bone grafting. Question 3, which of the following bone graft substitutes has the fastest resorption characteristics? So I like questions like this because I can categorize in my mind. If you think of the different bone graft substitutes that you have, just try to remember the differences between the two. So compressive strength, what's the greatest? It's for calcium phosphate. It's 4 to 10 times greater than the compressive strength of cancellous bone. The resorption rate, going fastest to slowest, the fastest resorbed one is calcium sulfate. Actually occurs in 5 to 7 weeks. This all goes all the way out to hydroxyapatite, which occurs over years. One thing that's related to this fast resorption rate is the drainage that you see with calcium sulfite. Maybe some of you guys have seen that in some of your patients. Going back to the question, which of the following bone graft substitutes has the fastest resorption characteristics? It's 1, calcium sulfate. 88% of you guys got that correct. That's awesome. Fracture healing. Question 5, which of the following statements regarding COX-2 is false? COX-2 is an enzyme. We've already covered it a little bit, but it's an enzyme which converts arachidonic acid to prostaglandins. It's not expressed under normal conditions, but elevated levels are found during general states of inflammation. The COX-2 knockout mouse has been shown to heal fractures more slowly than a COX-1 knockout mouse or normal controls. COX-2 inhibitors block fracture healing more than NSAIDs, and the magnitude of this effect is related to the duration of treatment. And NSAIDs inhibit both COX-1 and COX-2. So remember your COX knockout mouse. This is not a knockout mouse. A knockout mouse is a mouse where we specifically inhibit one gene to see its effect on the downstream product of that pathway. So the correct answer here is 2. COX knockout mouse heals fractures more quickly than control mice. This was a tough question. Only 55% of you got it correct. Let's look at answer 1. It causes mesenchymal stem cells to differentiate into osteoblasts. That is a correct statement. COX-2 does cause mesenchymal stem cell differentiation into osteoblasts. The rest of the answers were a little bit scattered, so we won't cover those. Mitochondrial bone formation. Question 16. The fracture seen in figures A and B is most likely to occur through which of the following growth plate zones? Well, this looks like a Salter-Harris 2 type fracture. You can see that little spike right there. So which zone is that going to occur through? You got to know the cartilage growth plate. So going from the metaphysis on the bottom here up to the epiphysis on the top of the slide, you have to know your resting zone, proliferative zone, prehypertrophic zone, hypertrophic zone, and the trabecular bone that you'll see on a section. So physeal fractures occur through the zone of provisional calcification in the hypertrophic zone. This zone, hypertrophic zone, is divided into maturation, degeneration, and provisional calcification. And if you're going to guess on the exam, if you're completely lost, heaven forbid, if you're going to guess the hypertrophic zone. It's where most of the defects occur genetically. Some examples are shown here. The thought is that physeal fractures probably occur here due to the transition from the soft cartilaginous physis to the harder calcific metaphysis. Question 16, going back to the answers. Answer 5, 62% of you guys got it correct. Other answer was answer 2, 22%, the proliferative zone. Well, the proliferative zone isn't where the fractures occur. This is where you're going to see your achondroplast, gigantism, multiple hereditary exostosis. Normal bone metabolism. Question 7, peak bone mass attainment in both men and women is most dependent on which sex steroid? The estrogen pathway and normal bone homeostasis. Normally, estrogen prevents bone loss by inhibiting bone resorption. It is the most important sex steroid for peak bone mass attainment in both men and women. Therapeutically, estrogen decreases bone loss if started within 5 to 10 years of the onset of menopause. There are significant side effects, though. Heart disease, cancer. You have to weigh this with your medical therapist to see if your patient should be on therapeutic estrogen. Going back to the question, peak bone mass attainment, both men and women, is most dependent on which sex steroid. Remember your fat bastard. We got to have our estrogen. Correct answer 4, estrogen. 81% of you guys got that correct. That's awesome. Testosterone? Sorry, it's not this one. It's not the most important hormone. While testosterone, progesterone, growth hormone, and cortisol all have effects on the bone, they're not as significant as estrogen. Bone remodeling. 24. 25-year-old male sustains a transverse humeral shaft fracture that undergoes open reduction internal fixation with rigid compression plating. What kind of bone healing do you expect to see? This is your AO basic course. Primary bone healing, secondary bone healing. Primary bone healing is this reversion remodeling. It occurs with absolute stability constructs, your compression plates. These types of constructs heal without a visible callus formation. You see the cutting cones. This cutting cone way down here, you see this, the leading osteoclasts chewing through this bone, trying to form a new tail of bone behind them. On the contrary, secondary bone healing occurs when fractures heal through a callus. The relative stability constructs, like your intramedullary nails, typically allow for some micromotion or macromotion, depending on how good you are at putting them in, at the fracture site, leading to a callus, or the dreaded non-union. This healing occurs through this cartilage scaffold, this endochondral ossification. This is an absolute must-know for your exam and for the rest of your career in orthopedics. Question 24, 25-year-old male, humeral shafts, ORAF, rigid compression plating. What type of bone healing? It's 1, primary bone healing. 94, I think that's the highest we've got on any of these questions. This was kind of a softball question. You guys hit it out of the park. Next one, bone matrix. All of the following statements are true regarding osteocalcin except. So to get this question right, you have to know a little bit about the organic component of bone. The organic component of bone has collagen, your type 1. It's got bone, O-N-E, 1. Remember that one. Proteoglycans, matrix proteins, cytokines, and growth factors. So if you look at the matrix proteins, there are 3 types of matrix proteins in the organic component of bone: osteocalcin, osteonectin, and osteopontin. Osteocalcin is the most abundant non-collagenous protein of bone, secreted by the osteoblasts. Functions to promote mineralization and bone formation. It's inhibited by parathyroid hormone and stimulated by vitamin D. It can be measured in the urine as a marker of bone turnover or formation. Osteonectin, on the other hand, is secreted by platelets and osteoblasts. Plays a role through regulation of calcium. And lastly, osteopontin, it's an integrant. It's involved in cell-to-cell interactions. Back to the question. All the following statements are true of osteocalcin. These types of except questions are awful. You're not going to see these on the exam, but these are great ways to drive home learning points. Here, too, it's secreted by osteoclasts. It's except. All the following statements are true except number 2. 81% of you guys got that right because it's secreted by the osteoblasts, correct? So osteocalcin is the most abundant non-collagenase protein of bone. It is osteoblastic. It is a biochemical marker, and it is part of the organic matrix. Next topic, hypoparathyroidism. A patient with chronic renal disease would expect which of the following endocrine abnormalities? Got to know your bone homeostasis, and I include hypoparathyroidism in that. If you understand the calcium cascade with your parathyroid hormone, you're going to get a lot of these minutia questions right. So renal osteodystrophy, a pathologic bone condition in patients with underlying kidney disease. The most common endocrine abnormality in renal osteodystrophy is increased parathyroid hormone secretion. What happens is the kidney disease leads to decreases in serum calcium, increases in serum phosphate, and in response to these changes in serum calcium, the parathyroid glands secrete more parathyroid hormone. Don't make it any more difficult than that. Question 47, patient with chronic renal disease would expect which of the following endocrine abnormalities? This is a little cartoon to help you remember it. It's an increase in production of parathyroid hormone. That's awesome. 92% of you guys got that correct, so we won't belabor that point. Next question, renal osteodystrophy. Question 13, you're seeing a dialysis patient for a fragility fracture. Patient also carries a diagnosis of renal osteodystrophy. What's the key pathophysiological step responsible for the osteomalacia? This is how I feel about this question. Nonetheless, you got to get it right. The key pathophysiological step in renal osteodystrophy is the uremia-related phosphate retention. Remember, your hypocalcemia occurs because the kidney can't convert vitamin D into its active form, calcitrol. The damaged kidneys are not able to adequately secrete phosphorus. This causes insoluble calcium phosphate to form in the body, removing the calcium from circulation, leading to hypocalcemia, secondary hyperparathyroidism, and hyperphosphatemia. Back to the question. 13, dialysis patient, fragility fracture. What's the key step in renal osteodystrophy? Uremia-related phosphate retention. 72% of you guys got that correct. So let's look at answer 1. It's not actually a parathyroid hormone receptor problem. It's a minute difference, but in this case, it's the uremia that's the primary driving factor. Hyperphosphatasia. Hypophosphatasia is associated with which of the following laboratory abnormalities? Just got to know it. Low serum alkaline phosphatase levels. So hypophosphatasia is an autosomal recessive disorder caused by an error in the production of alkaline phosphatase. This leads to a low serum alkaline phosphatase level. Alkaline phosphatase can be used as a marker for bone formation, and it's actually elevated when bone formation is increased. You can look at several urine markers as a diagnosis of hypophosphatasia. Back to the question. Correct answer. Hypophosphatasia is associated with which of the following lab abnormalities? It's 5, decreased serum alkaline phosphatase. This was a tough one. 58% of you got it right. So let's look at answer 4. Answer 4, decreased serum phosphate. So this is actually the alkaline phosphatase. Remember, your hypophosphatasia leads to a low alkaline phosphatase. Mark DeHart created this little acronym, and so I think it's a brilliant way to remember this, and I appreciate him letting us use it. So rickets, next one. Question 11. Loss of function of the 25-hydroxy vitamin D alpha hydroxylase gene, that's a mouthful, causes which of the following diseases? Rickets. It's a defect in mineralization of the osteoid matrix caused by an inadequate calcium and phosphate. It occurs in the zone of provisional calcification, leads to increased physeal width and cortical thinning and bowing. There are many different types: vitamin D dependent, familial, vitamin D, that's a typo, renal osteodystrophy, and hypophosphatasia. We got vitamin D dependent, it's deficient independent, sorry, not a typo. Question 11, loss of function in this gene causes which of the following diseases? Correct answer 3, hereditary vitamin D dependent rickets type 1. 70% of you guys got that correct. That's awesome. Let's look at answer 2. Vitamin D resistant ricket, the familial hypophosphatemic rickets, is caused by a deletion of the PHEX gene. It results in low serum phosphorus, elevated alkaline phosphatase, and normal calcium. Another one to remember is hypophosphatemia caused by the GALANT3 gene. You're looking at your hereditary, answer 4, the hereditary vitamin D dependent rickets. Type 2 is caused by a defect in the intracellular, there's 2 in there, receptor for vitamin D. Genetic pearls. What serum marker is most closely associated with colorectal carcinoma? Tumor antigens, something that you just got to commit to memory. These are probably the 5 most common used ones, something that would be great just to jot down on a piece of paper before you go into your exam. Tumor antigens, used in the diagnosis, monitoring of treatment, and currently being researched for treatment options as potential anti-cancer vaccines. If we know these antigens are associated with these cancers, why not use them to treat? So colon cancer is seen with CEA, CA19-9, pancreatic cancer, CA125, ovarian cancer, CA15-3, breast cancer, and alpha-fetoprotein, many cancers, but it's most commonly seen in liver cancers. Back to the question, what serum marker is most closely associated with colorectal carcinoma? Your correct answer is 2, CEA. 80% of you guys got this correct. This is actually a patient of mine that walked into our oncology clinic with colon cancer. This is a giant metastasis where he's basically developed protrusio and a pelvic discontinuity from his disease. Difficult situation. All right. Collegiate football player is hit in the thigh, 29, by opposing player's helmet. Radiographs are unremarkable, and the player is diagnosed with a muscle contusion. Which of the following cells appears first in the thigh following the injury? So muscle injury. Let's look at it. Neutrophils are actually the first listed cell. So this is a little bit of test taking. Let's go back and look at this. Question is asking for the first listed cell to appear. They're not the first cell that appears. The first cell that appears is a red blood cell with your hemorrhage. So the neutrophils are the first listed cell to appear following acute muscle injury. Inflammation causes these mononuclear cell chemotaxis and a massive influx of neutrophils to the injury site, releasing further pro-inflammatory cytokines. Following this initial phase, the macrophages arrive to phagocytize the debris. And the neutrophil presence and free radical generation is thought to be associated with the scarring and the muscle damage that your sports medicine doctors are seeing in their clinics. Back to the question. 29. Collegiate football player hit in the thigh by an opposing player's helmet. Radiographs are unremarkable and the player is diagnosed with a muscle contusion. Which of the following cells appear first in the thigh following injury? 92% of you guys got this correct. That's awesome. If we look at the incorrect answers, 1, 3, and 4, anytime you see blast, this is a little nugget just to tuck away in your memory bank. Blast means some type of a precursor cell. So oftentimes blasts they're going to be the cells that are going to be in your marrow. They're going to be your mesenchymal stem cells that are trickling through your fat or your muscle or in your bloodstream. These are not going to be the first to arrive. Looking at your eosinophils, they're immune cells. They're typically involved in allergy and asthma, not going to be involved in this general inflammation of a muscle injury. Next topic, cartilage. SOX9 is a key transcription factor involved in the differentiation of which of the following cell lineages? Cartilage. It's formed from these prechondrogenic mesenchymal stem cells. It requires activation and migration of appropriate precursor cells to the correct location. SOX9 is considered a master switch for the differentiation of cells of the chondrogenic lineage. SOX9 binds to a critical consensus sequence in the collagen II promoter to activate its transcription. Retinoic acid has been implicated in the process of cartilage formation. Going back to the question, 19, SOX9 is a key transcription factor involved in the differentiation of which of the following cell lineages? Correct answer, 3, chondrocytes. 70% of you guys got that correct. That's great. So let's go through these incorrect answers. 1, 2, and 4. Well, SOX9 isn't actually involved with osteoclasts or osteoblasts. Number 5, SOX9 is not a transcription factor to transmembrane tyrosine kinase receptor. Not the case. SOX9 is not a transmembrane tyrosine kinase receptor. It is a transcription factor. Next topic, peripheral nerves. 22, vitamin B deficiency is known to cause which of the following? Vitamin B, it's important for hematopoiesis and CNS maintenance. Deficiencies are a common cause of peripheral sensory neuropathy. B12 levels should be evaluated in patients presenting with peripheral sensory neuropathy. Some signs of B12 deficiency, you get a decrease in your deep tendon reflexes. You get your pathologic reflexes like your Babinski's. You can have fatigue and depression. Back to the question, vitamin B deficiency, known cause of which of the following? Well, the correct answer here is 2, peripheral sensory neuropathy. Not that you can't whistle, that's FSH muscular dystrophy, right? Number 3, B12 deficiency causes a decrease in your deep tendon reflexes. Mania, B12 deficiency actually causes fatigue and depression, not mania. And hydrophobia, that's what you see with rabies. The next topic is the antibiotic drugs. Question 48, MEK-A is a bacterial gene which encodes for penicillin-binding protein that alters the efficacy of beta-lactam antibiotics. Which of the following species of bacteria are known to produce MEK-A? This is a must-know in your antibiotics classification. So MRSA, it's the most common carrier of the MEK-A gene. MEK-A can also be found in Streptococcus pneumoniae species. What MEK-A does is it alters the bacterial susceptibility towards penicillin by forming this penicillin-binding protein. The penicillin-binding protein is a membrane-associated protein which shows low affinity to penicillin-like antibiotics. A small little nugget of information that might help is that this MEK-A is expressed on a plasmid. So a plasmid is DNA that's in a short sequence, usually some type of a ring or the like, different from the bacterial genome that can be transferred from one bacteria to another. Back to the question. MEK-A is a bacterial gene which encodes for penicillin binding protein that alters the efficacy of beta-lactam antibiotics. Which of the following species of bacteria are known to produce MEK-A? Correct answer is 4, methicillin-resistant Staph aureus. So it looks like 97% of you got this correct. That's awesome. If we look at the incorrect answers, C. diff and C. tetani, they don't harbor MEK-A. VRE shows resistance by the VAN genes, which also alter the vancomycin binding site, the D-allodylamine. And only MRSA harbors MEK-A, that's MRSA, excuse me, MRSA harbors MEK-A, not strep epi. Next topic, molecular biology basics. What is the post-amplification product of reverse transcriptase polymerase chain reaction? This question has generated a lot of questions by takers on Orthobullets. So let's go through it and make sure everybody understands. So PCR, polymerase chain reaction, it's a tool. It's a molecular biological tool that's only used to create copies of DNA. So you see PCR, you think DNA. What it does is it uses short primers of DNA to help amplify some segment of DNA. The way that it does this is via this temperature-mediated enzyme, DNA polymerase. So reverse transcriptase polymerase chain reaction, RT-PCR, remember, you see the PCR, you think DNA. The difference here is that reverse transcriptase takes RNA back to DNA for the DNA to be amplified. So it's a variant of PCR. It generates many copies of DNA from fragments of RNA. Remember, PCR, DNA. So what RT-PCR does is takes RNA back to DNA and then amplifies it. So looking at the question, what is the post-amplification product of reverse transcriptase polymerase chain reaction? Well, the correct answer is 2. It's DNA. Only 57% of you got this correct. One way to think about this is remember your central dogma of molecular biology. DNA goes to RNA via the process of transcription. RNA goes to protein via the process of translation. So remember, script, the C comes before L in the alphabet. So transcription comes before translation. Reverse transcriptase takes the RNA back to DNA. So let's look at the incorrect answers. RNA, I know this is a difficult one. RT-PCR, C-PCR, think DNA. So RNA, we don't have actually a good way to amplify DNA. The only thing we can do is take RNA back to DNA, then amplify it. 3, protein, the product of RNA translation, and it's not affected by PCR. Mitochondria, the powerhouse of the cell. It generates the ATP. Immunoglobulins, they're antibodies made by B cells. They're not involved in RT-PCR. Next topic, clinical trials. Which of the following study designs represents a level 3 evidence study? Your pyramid of level of evidence is something you have to know. Your level 1 studies, randomized controlled trials. Your level 2, prospective controlled trials. Level 3 include retrospective cohorts and case control studies. Level 4, case series. Level 5, case report, expert opinion, personal observation. I put down here level 8, that's my opinion, I don't matter. 43, which of the following study designs represents a level 3 evidence study? Correct answer is 2, a retrospective case control study. Only 80% of you got this correct. So let's look at answer 3, the second most chosen one. Case 3, a case series. So that's a level 4 study. You have to have a control group for it to be a level 3. Again, level of evidence. Let's hit it home. Using level of evidence in research studies, which of the following represents a level 2 study? Again, same slide. Randomized controlled trial, level 1. Prospective cohort, 2. Retrospective cohort study or a case control, level 3. Case series, 4. Case report, expert opinion, 5. Using level of evidence in research studies, which of the following represents a level 2 study? Correct answer 2, prospective cohort study. 88% got that correct. That's excellent. Occupational health. When using C-arm fluoroscopy, patient radiation exposure will be increased with which of the following? Radiation exposure is increased if a larger body part is imaged, the extremity is positioned closer to the X-ray source, large C-arm gives more radiation than a mini C-arm. So factors you can use to decrease radiation exposure: minimize the time, maximize the distance. Use a columnator. The columnator, what it does is it focuses the X-ray beam. So the columnator functions like a comb, and it hones down that beam so that less radiation, less scatter gets to the patient. You can use the inverted position relative to the patient, like this seen up here. This is what we always did during residency. It's something that I never understood, but when you're doing those supracondylar fractures in kids, you flip the machine over, use this as your base plate to do your reduction. At the same time, you're getting good images and you're decreasing your radiation exposure for the child. Finally, use your protective shielding. So you always got to wear protection. Since I have a European background, this level of protection is perfect for me. When using C-arm fluoroscopy, patient radiation exposure will be increased with which of the following? Correct answer is 2. A larger body part is imaged compared to a smaller body part. So only 77% got that correct. Let's look at answer 1. Closer to the II, the image intensifier decreases the exposure. Number 3, the beam collimator decreases scatter and exposure. Number 4, the mini C-arm decreases radiation exposure. Number 5, decreased imaging duration decreases exposure. Statistics definitions. What term in statistics defines accepting the null hypothesis when it is in fact not true? You must know. This is something that's the new wave of orthopedics, because everybody's recognizing the amount of beta errors that are occurring in orthopedics. So a type 1 error, the null hypothesis is rejected, even though it is in fact correct. One example of this would be to say, well, does chiropractic manipulation affect asthma? Our null hypothesis would be, nope, doesn't affect asthma. But what we can see is some of our colleagues in chiropractic medicine do actually believe that chiropractic manipulation affects asthma. So your null hypothesis is rejected, even though it is in fact correct. Type 2 error, remember the 2, the null hypothesis is accepted. There are 2 C's in accepted, even though it is in fact not correct. So one example, data suggests aspirin is not effective in preventing death from acute myocardial infarction. Type 2 errors are due to inappropriate study power, aka the false negative rate or beta error that's being made. The study power is the chance of detecting a true positive if one actually exists, and it's 1 minus the beta. So type 2 error is common in orthopedics. You can avoid it with appropriate pre-study power calculations and sample size calculation. Question 28. What is the term in statistics that defines accepting the null hypothesis when it is in fact not true? Well, your correct answer is type 2 error. 71% of you got that correct. So let's look at this. Type 1 error, this is where you reject the null hypothesis. Not accept it, you're rejecting the null hypothesis. Number 3, bias, a selection bias as an example, where certain people are more likely to participate in research than others, which skews the data. 4 and 5, predictive values. How likely does a positive or negative result on a diagnostic test occur in somebody with or without that disease? Question 37. The statistical power of a study is best defined by your study power. You have to know the study power. This is the ultimate power. This is me before hair and makeup tonight. Study power is an estimate of the probability of finding an association in a research study when one actually exists. And the power is defined as 1 minus beta, or the type 2 error. Appropriate powered studies are those with about 80% of power, i.e. there's less than a 20% chance of a type 2 error. This also is another way of saying there's an 80% chance of detecting an association, and a 20% chance of randomly missing it. So statistical power of a study is best defined by Answer 1 minus the probability of a type 2 beta error. 79% of you got that correct. Let's look at answer 4. 1 minus the probability of a type 1 error. This is the key differentiator on this question, is knowing the alpha versus the beta and which one is associated with power. Outcome measure tools. 45-year-old male trauma patient presents with multiple extremity injuries, including a foot injury shown in Figure A. The foot fracture is treated surgically and heals without initial complications. At a minimum of 12 months, this patient will be expected to have which of the following scores compared to matched polytrauma patient without a foot injury? So you're looking at this, you have an x-ray. This isn't actually an x-ray question. This is a pull it from your brain question about what are the outcome measure tools in foot patients. So let's look at them. Outcome measure tools allow for quantified measurement of patient outcome. The ideal outcome measurement tool is both validated and reliable. So this little cartoon helps to understand this. So in this situation, in this bullseye, the person doing the shooting is reliable. They're always in the same spot, but they're not valid. They're not next to the true norm. Here, this is an example of low validity and low reliability. Not only are they scattered away from the true norm, they're not in the same area. Again, not reliable, not valid. Finally, a test that you want is both validated and reliable. You see the precision is high because the reliability is all very clustered next to each other, and it's validated because it's next to the known norm. So to answer this question, you have to know that foot injury independently predicts poor outcome in a polytraumatized patient. You've all seen this. Your patients with a femur fracture, a pelvic injury, a head injury, if they get a Lisfranc, you know that they're not going to do very well. The SF-36, the WOMAC, the Modified Boston Children's Hospital Grading System, and the AAOS Limb, Foot, and Ankle Questionnaire all validate this. So the big picture is that more attention needs to be paid to these patients, and what can we do to optimize their outcome? Back to the question, 45-year-old male, multiply injured, foot injury is shown at a minimum of 12 months. This patient will be expected to have which of the following scores compared to matched polytraumatized patient without a foot injury? Well, the correct answer is 1. Lower mean SF-36 score. 84% of you guys got this correct. That's awesome. Hip biomechanics, our last topic. Question 31. Figure A represents a free body diagram of the hip of a patient standing on the right leg. The forces and distances are labeled on the diagram and resulting hip joint reactive force, J, of 1800 newtons. What is the resultant value for the hip joint reactive force, J, when the acetabular component is medialized, giving the new distances shown in Figure B? So the differences between here are the A and the B, so 50 and 100 versus 50 and 50. So free body diagrams show the locations and directions of all forces and moments acting on a body. The body and the left leg weight of about 5-6 times total body weight in a right leg stance, single leg stance. The joint reactive force decreases as the acetabular component is moved medial. This is because of decreased abductor tension. What you're looking to strive for is mechanical equilibrium, where the sum of all forces at the moment equals 0. So the two equations that you need to remember are the one for abductor tension and the one for joint reactive force. And we'll go through these on the next slide. The correct answer here is 2, 1200. So let's see how we get here. If we look at the bottom diagram here, the first step that you need to do is determine the new abduction tension with a B of 50. So again, here's that first equation, AT times A minus 5/6 body weight times B has to equal 0. All the forces have to sum out to 0. So if you look at this, AT times, and simplify it, AT times 50 has to equal 3,000. So your new abductor tension is 600 newtons. What you do is you then plug that into your second equation to determine the new joint reactive force. So J equals abductor tension times 5/6 body weight, or J equals 600 newtons plus 600 newtons, or 1200 newtons. That's how we get to answer 2. So let's sum up this portion of it, the top 10 as I see it. Number one, you have to know your statistics definitions. There's going to be a question on your exam, at least one, of alpha, beta, power questions. Number two, immunology. I really like immunology. Not everybody does, but you're going to see it. You're going to see a psoriatic patient, a rheumatoid patient, a general immunological question. The immune response, fracture healing, it's all related to immunology. Number three, antibiotic drugs. In addition to knowing their mechanisms of actions, you have to tuck away those little facts like the MEK-A gene, things that are going to confer resistance to some of our bacterial strains. Related to that is the MRSA, vancomycin, and MEK-A pathway. Number five, one of my most favorite is the rank ligand OPG pathway. Remember, rank ligand, secreted by osteoblasts, acts on osteoclast precursors to stimulate them. It tickles them in just the right way that it turns them on. OPG is also secreted by osteoblasts, and it decreases the function of the osteoclasts. Number six, bone homeostasis. So your cathepsins, your calcitonins. Remember that calcitonin acting on the calcitonin receptor to decrease resorption by signaling through the cell signal cascade, and also decrease the gene product of the calcitonin receptor. An easy one to remember is your central dogma of molecular biology, your PCR and your molecular biology basics, knowing that you go from DNA, transcription to RNA, translation to protein. So remember, the C in transcription occurs in the alphabet before the L in translation. That's why transcription occurs before translation. And the reverse transcriptase takes the RNA back to DNA. And if you're going to see anything on PCR, PCR only does one thing. It's a tool. It amplifies DNA. It does not amplify RNA. It amplifies DNA. Number eight, levels of evidence. You have to know your pyramid. Look at it before you go in and memorize it. There's going to be one or two questions on it. Number nine, the types of immunological reactions, 1 through 4. And number 10, the dreaded calcium pathway of calcium, phosphate, hypophosphatasia, rickets, all of these things, renal osteodystrophy. Commit them to memory. Spend a couple minutes because you're going to get key testable points here if you can get those questions right. So I'd like to thank everybody. I'm really sorry about all the technical difficulties we had on my portion of the webinar. I hope this helped, and please don't hesitate to contact me through Orthobullets. And I wish you nothing but the best.
Mark DeHart from Austin, Texas, and when he can either add on at the end of this, or if he wants to sneak in again, he can. I want to try and keep it going. I've got sort of a potpourri of basic science topics, and some of the slides, if you've been in the Miller course, you'll see that are a little bit similar, but the questions are all different. The first question we've got is on orthopedic implants, and the question reads, which of the following techniques increases the strength and the stability to an external fixation construct? They're trying to see how much you know about the biomechanics of an X-fix. Some basic principles that are worth knowing are that two cortices are better than one. Separating the pins is a better form of stability. Pins closer to the fracture gives you more stability. The shorter the pins, the better, and so the hippo pin is better than the elephant pin. And then size matters. Like a lot of things in life, bigger pins are better pins. So if you read through the question again, the preferred response that almost all of y'all got was answer number 4. Next question is, a 25-year-old male sustains the fracture seen in figure A and undergoes open reduction internal fixation. What type of plating technique is used for the ulna? Well, the first part is you got to know which bone is the ulna, and that's helpful. And you can see that this both bone forum fracture has a comminuted segmental ulnar fracture, and then they put some plates on it. So you need to know the different kinds of plating, and they give you a long list that we'll go through briefly. A neutralization plate spans the fixation of a frag screw usually, and so this is an example of a neutralization plate. The locking plate, the screws usually have head threads that lock into the plate, and that's the fanciest new plate. Once upon a time, the compression plate was the fancy plate, and the compression plate has offset screws in their oval holes that are placed to load the bone in compression that allows for primary bone healing. The bridging plate is an extramedullary splint. It's like an on-the-bone external fixator, and it spans a gap. So when we get back to the question and we figure out which bone is the ulna, it is clearly answer 4, and all of y'all got it, so that's the way to go. Next topic is kind of a unusual potpourri topic, rehabs and prosthetics, and we'll start off with question 40. For an above-the-knee amputation, each of the following is a benefit of adductor myodesis except. Again, this is one of those except questions, and the boards, they're really trying to get away from it. They're trying to test your, your retention, not really your IQ under stress. But above the knee amputation, the adductor myodesis improves the clinical outcomes by creating a dynamic balancing force. It helps ambulate, and it provides a soft tissue envelope that enhances the prosthetic fitting socket. So when we go back to the question and read through the answers, this was a little bit tougher, but still almost 90% of you got it. It's answer number 1. The one that doesn't do, the one that the adductor myodesis doesn't help with, is giving you a longer leg. The next question is also prosthetics. A patient with a transradial amputation, they're considered the best candidates for a myoelectric prosthesis. Each of the following are advantages of a myoelectric device compared to a body control device except. Again, it's an except question, and so it's worth thinking about the difference. The picture on the left is a body control device. It's a cable a harness grip that you can see, and the one on the right is a myodesis prosthesis. The myoelectric prosthesis is the best candidate for the transradial amputation. It provides good cosmesis because you can make the fingers look just about any way you want, but it is heavier. It's really better for sedentary work. There's less sensory feedback because you don't even get to feel how hard you're pushing against it, and it can be used for overhead activities. So when we get back to the question, the answer, which was a little bit tougher for y'all, was number 3, more sensory feedback. It doesn't provide any more sensory feedback, and the body cable device probably gives you a little bit of sensation because you have to use your arm to push around to make the clamp close. We're going to, as long as we're talking about metal things, we're going to go to material properties for a slide. The question reads, what description below best describes galvanic corrosion? And so they list a bunch of different kinds of corrosion, and they want you to be able to distinguish between them. Now, corrosion is the process of interaction between a solid material and its chemical environment, which leads to either a loss of substance, a change in its structural characteristics, or a loss of structural integrity. Crevice corrosion is where there's wear in a constricted place where the oxygen exchange just isn't available. Fretting corrosion is a special wear process that occurs at the contact area between two materials under load and that are subject to relative motion by vibration or other force. So fretting, think of load and force. Pitting corrosion is just that, localized symmetrical corrosion where there's tiny holes that form on the surface. And then galvanic corrosion is a wear when there's two different kinds of metals that are close together with a difference in their electric potential, and that causes a current to flow through them and advances the corrosion. So when we go back to the question, which one is galvanic corrosion? The one that results from electrochemical potential is galvanic, and that's the one to remember. When you look at answer number 2, and I guess all of y'all got that one right, so we don't have to, but the corrosion results from contact sites between the materials under loads, that's fretting. Crevice is the oxygen tension, and then pitting usually has the words pitting in it, and I have no idea what kind of corrosion from allergic reaction is. The elements chromium, molybdenum, and cobalt are the basic components of which of the following implant materials. And then they give you a list of a bunch of different implant materials. One of them is aluminum oxide, and you should know the elements there. This slide shows the Young's module of metals and biologic, because unlike the last question, which most of y'all should probably get correct, this is a question that will certainly be on the boards. It's on every OITE, and it's going to be on the boards, and they may even ask you this on your oral boards. And the question is, the more metallic or stiffer substances on the Young's modulus, which is a measure of stress versus strain or stiffness, are the metals and ceramics at the top, and the biologic things are down at the bottom. If there's questions they like to ask, it's which metal is closest to bone, and that's of course titanium. And then you know that the ceramics are the most stiff, so that's going to be way up high. And then all the biologic materials are down at the bottom, except for cortical bone, which sneaks above PMMA. So when we get back to the question, they're asking about the elements. And number one, you know what aluminum oxide is. It's aluminum and oxide. And so the real question should be between the cobalt alloy and stainless steel. Now, stainless steel is iron with chromium in it, and that's what makes it less likely to corrode. The cobalt alloy, which is the most common one we hear about, or the most famous one, was Vitalium, that was made by the Stryker company. And then PMMA is plastic, so it's not an answer. And then tantalum is its own element. And so they gave you the answer in the question, cobalt. Talking about metals, we'll sneak on to lead toxicity. Lead toxicity affects growth by inhibiting which of the following factors? And this is a tough one, so I'll be surprised if the answers are as high on this one, but it is important to learn just a little bit about lead. And lead, if you don't remember anything about lead, remember plumbism, because plumbum is what lead was called in Latin. So PB stands for plumbism, and the P is for painful, and the B is for belly. Painful belly, because in the medical literature they get colic and constipation and tummy pains, but P is also for polka dotted red blood cells. They may show you those basophilic stippling on a slide that you need to know about. And then peripheral palsies. And the classic orthopedic question for lead toxicity is a radial nerve palsy. And so if you ever see a radial nerve palsy and it's not someone who's been drinking with their arm over their chair, think about moonshine and think about lead toxicity. Now, plumbism is PB, so B is for those blue gum lines, the Burton's gum lines, the basophilic blue stippling on the red cells, and B is for the bright bony bands of the metaphysis and growing bones that you can see on the slide on the bottom. So when we get back to the question, lead toxicity affects growth by inhibiting. Number 2 is the answer. A really difficult question, and I'm not sure I could have got this before I had to study this question. But lead blunts those 2 critical regulators of chondrocyte maturation, parathyroid hormone-related peptide, and transforming growth factor beta. And the choice they gave you was PTHRP. So number 2, and that's the one that's going to distinguish that upper 1.5%. Next big topic we'll go to is anticoagulation, something near and dear to my heart as a joint doctor. The question reads, which of the following medications exerts its influence on the clotting cascade by replacing normal clotting factors with decarboxylated factors? And they give you the long list of medicines, and so mechanism of actions for these medicines are pretty important. Everybody should remember that warfarin works here in the liver, and it affects 2, 7, 9, 10, and protein CNS, and those are things you've learned since medical school. The harder question to ask is, well, how does it work? And the diagram on the right shows how warfarin blocks the vitamin K reductase, and so it changes so that there are no gamma carboxylative factors. Now, the other question they always asked on the blood clot questions is Virchow's triad, and he figured this out in the 1700s, that blood clots are related to endothelial damage, hypercoagulability, and stasis. There's almost always a question on that, so you remember those 3 things. You thought you got away from the clotting cascade when you made it into your orthopedic residency, but here it is again. Those things that cause hypercoagulability are things that block the clotting cascade. And the clotting cascade's nothing fancier than a big chain of Roman numerals that ends at factor 2A, which is thrombin. And remember, factor 2A thrombin converts the soluble fibrinogen to an insoluble fibrin product. The 2, 7, 9, and 10 are all those Roman numerals. So the medicines that they're going to ask you about include a whole host of these other medicines, and acetaminophen's thrown in here as a bonus. It inhibits prostaglandin E2 via IL-1B. We already talked a little bit about aspirin. It irreversibly binds the cyclooxygenase and platelets. Nonsteroidals inhibit both COX-1 and COX-2, and then celecoxib is the only one on the market now that inhibits COX-2. Coumadin, the drug of the day, works by preventing the vitamin K gamma carboxylation in the liver, and so it affects 2, 7, 9, 10, and protein C and S. Heparin and low molecular weight heparin work by reversibly binding factor 10A through antithrombin 3 and thrombin, and then fondaparinux irreversibly binds factor 10 through antithrombin 3. Rivaroxaban has that XA in the middle of it, and it inhibits factors 10A. And then as a bonus, the Herudins are direct thrombin inhibitors, and the oral version is dabagatran out on the market now. So when we get back to the question, which one works by replacing the normal clotting factors with decarboxylated factors? The answer, number 1, and nearly all of y'all got it right. Way to go. A little bit more on blood clots. The 2009 American Academy of Orthopedic Surgeons Clinical Guideline on the Prevention of Pulmonary Embolism in Patients Undergoing Total Hip and Knee Arthroplasty recommends classifying patients as either having a standard or elevated risk of bleeding complications. The presence of all of the following qualify a patient as having an elevated risk of bleeding except, another one of those except questions, so just put your thinking hat on when you answer any kind of question that ends in except. Now, the clinical practice guidelines that are more recently come out preventing thromboembolic disease are also ripe for questions because nothing's very new here. You want to assess the patient if they have a history of a blood clot before. You want to assess if they have bleeding risk, things like liver failure and hemophilia. You want them to discontinue their platelet inhibitors. You want to give them drugs and an intermittent pneumatic compression hose if they have normal risk, and drugs and a compression hose if they have a prior DVT. If they have high bleed risks, then most people will just use the intermittent pneumatic compression hose. Everybody thinks that getting your patients out of bed and out of the hospital as quick as you can is good. Neuraxial anesthesia is used sometimes to help decrease blood clots and bleeding. And the most strong recommendation in the guidelines is don't recommend duplex screening for your routine patients. It's a great test to find clots, but not to screen for them. So when we get back to the question, what they're asking is, all of the following includes the patient having an elevated risk except, well, hemophilia makes you bleed, a GI bleed, you already bled, a hemorrhagic stroke, you already bled, and you do need to know that von Willebrand's disease makes you bleed. So everything bleeds in this question except for number 2, and that's why 91% of y'all got it right. We'll talk a little bit about fat embolism syndrome, and as an old guy, when I studied for my boards, we used cassette players. That was a thing that had tape in it, and you put it in the machine, and you had to have batteries. Now we got this technical nightmare to try and make all this happen for you, and it seems to be going okay for me. Sorry, Pat. The question for fat embolism syndrome is, in a patient undergoing total knee arthroplasty, the etiology of fat embolism syndrome is most likely due to, and they give you a list of things that it could be due to. Remember, when we talk about fat embolism syndrome, if you had a transesophageal echo in every hip and every total knee you did, and looked at it at the critical time, you'd notice showers of tiny clots and fat that goes through your right heart, every time. When we do a total knee arthroplasty, the etiology of fat embolism syndrome is most likely due, well, we hope it's not most likely due to a femur fracture because you're doing your knee wrong if that happened. It's not due to blood loss. Cementation might be an answer for a total hip question, but probably not for a total knee question. And cerebral ischemia is what you might get from fat embolism syndrome. So the answer is number 2. A few more of y'all had problems with that one, and I think the cementation is what drew you off. So I think it's the metal rod that you jam in the thigh bone that causes the fat embolism is much more likely than the cementation, unless it was a total hip question. So we ought to talk a little bit about fat embolism syndrome because it's a classic orthopedic question that always gets asked. And the pathognomonic finding for fat embolism syndrome is a petechial rash that floats up to the upper anterior aspect of the body because, of course, fat floats. You'd see it on your chest and sometimes as high as your eyes. It also goes to your brain, and that's what causes the neurologic symptoms. This is an autopsy specimen from someone who had a fat embolism syndrome, and that explains why people get confusion, stupor, rigidity, convulsions, and sometimes coma. It also, the fat globs go to your lung after it goes through that right heart, and the pulmonary symptoms are the exact same thing as ARDS, hypoxia, tachypnea, dyspnea, and tachycardia. And if you take a chest x-ray, you see this white-out snowstorm lung, either on the chest x-ray or the CAT scan. And if you biopsy that lung, you might see little fat globules like the alveoli show on the right. Now, the other thing that's frequently in the test stem is a biphasic clinical asymptomatic interval. So immediately the fat globules go up into the lung and they block vessels in either your brain, your lungs, and after about 24 to 72 hours, those fat globules are hydrolyzed into irritating fatty acids, and those fatty acids stimulate the complement system to create the ARDS and other problems that we see. So you start off with a patient who's riding his motorcycle, breaks both of his femurs, he's sitting there in traction waiting. Oh, you don't do that anymore. He's waiting to get his surgery, and he's laughing and kidding around, and for some reason his surgery gets canceled for the next day or two, and then the next day you come in and he's dead, he's had seizures, or he's had some terrible, he's on the respirator, and that's the clinical position that you're going to see for fat embolism syndrome on the test question. Well, we'll leave some of those terrible things that happen in orthopedic and move on to articular cartilage and some arthritis questions. This question is, what part of the articular cartilage has the highest concentration of proteoglycans? So we were talking about articular cartilage layers. The H&E slide on the left shows that there are differences even on the H&E slide from the cartilage surface where the synovial fluid is down to the bony surface on the bottom. You can see on the first EM section that there are some flat cells on the top and some round cells with bone crystals on the bottom. The proteoglycan slide shows that there is a difference in the amount of proteoglycan. And look way up at the top. You see it's a little bit lighter and grayer. That's because the proteoglycan is a little bit less up there. The far right are collagen fibers that are looked at an electron micrograph, and you can see that they change. There's a different orientation between them, and let's talk a little bit about that. The superficial cartilage layer, or the tangential zone, is the one closest to the synovial fluid. It's covered with the thin lamina splendens. It is characterized by flat chondrocytes, and it has the highest concentration of lubricin, superficial zone protein, and proteoglycan 4. It also has the highest collagen percentage, and the fibers of those collagen are oriented tangentially to provide strength against shear. It's also the most deformable cartilage. Now, it has the highest water, and that makes perfect sense since the synovial fluid is right on the other side, and cartilage is built to absorb that water by bringing sulfate ions to bear with osmosis. It also has the least proteoglycan synthesis, as we saw before. The deeper layer, the deep cartilage zone or the radial zone, it has vertical collagen fibers, and it has some of the largest diameter collagen fibers because it provides strength versus compression. There are plump chondrocytes, and it has the highest level of proteoglycan and the lowest amount of water. Finally, at the very bottom near the bone, where the calcified cartilage zone is, it starts at the tide mark and it transitions all the way to bone. Another test question might be what type of collagen is found down there at the tide mark, and it's type 10 collagen. It's rated X collagen, so remember, if it makes things hard, it's rated X, that's type 10. It's also worth knowing that injuries below the tide mark can heal with fibrocartilage, but injuries above that rarely heal at all. So the question was, what part of the articular cartilage has the highest concentration of proteoglycans and the lowest concentration of water? The answer is the deep layer. And although most of you all got it, that's a pretty tough question if you don't think about cartilage very much. So remember, the superficial zone has the highest amount of water. Now, as long as we're talking about collagen, we ought to remember that when we're talking about cartilage, the type of collagen that's there is type 2. 90 to 95% of cartilage is collagen is type 2. It's the same collagen that we find in the eyeball and in the nucleus pulposus of the disc. We discussed type 10 collagen a minute ago, and that's the calcified zone of the articular cartilage, but it's also found in the hypertrophic zone of the growth plate. Remember, type 10 collagen is only near calcified cartilage. Again, if it makes things hard, it's rated X for mineralization and calcification. We all remember that type 1 collagen is in the word bone, and so type 1 collagen is in bone. It's also in tendon, the meniscus, the annulus of the disc, and in skin and scar. If you have a type 1 collagen defect, the disorder most likely tested is going to be osteogenesis imperfecta. Since it affects the bones, they get osteoporosis and weak broken bones. Since it's also found in the conjunctiva of the eye, the sclera of the eye, sometimes people with osteogenesis imperfecta have a blue sclera. The other kind of collagen disorder that sometimes involves type 1 collagen is Ehlers-Danlos syndrome, the rubber man, because type 1 collagen is found in skin. All right, osteoarthritis, a little question there. According to the recommendations made by the American Academy of Orthopedic Surgeons in their clinical guidelines for the treatment of osteoarthritis of the knee, all of the following non-operative modalities are supported by the literature, except they talk about weight loss, activity modifications, quadricep strengthening, and different kinds of injections. Now, this is straight from the guidelines, and intra-articular injections gets their own little section. Probably good test technique. If there's two answers that are saying the same, one of them is probably the right answer. According to the Academy, though, intra-articular steroids have good evidence for short-term release, but the use of intra-articular hyaluronic acid for mild to moderate symptomatic is really inconclusive with pretty high levels of data. And there was a recent article in the internal medicine literature about this as well. So the question is answer 4, and most of y'all got that right. That's glad to hear that y'all aren't going to waste all of our tax money. The next topic goes along with arthritis. It's gout. It's a special time at gout. The question reads, a 60-year-old man has had an intermittent pain in his right great toe for the past 2 years. What is the most likely cause for the lesions indicated by the arrows? Well, since you titled the slide gout, it takes away all the guessing here. If everybody didn't get this one right, we're in trouble. So if you look where the tophus is, that's what a tophus looks like, and it dissolves that bone away. Remember from medical school, UPAN, yellow urate parallel to the compensator. These crystals are negatively birefringent, and they are needle-shaped. The other crystal they could show you with any frequency is calcium pyrophosphate disease, and those crystals are blue and positively birefringent. So those blue crystals are usually squattier square crystals, and they may show you an x-ray with calcium crystals inside the cartilage or an arthroscopic picture where you can see the white globs of calcium. So we get back to the question, and I'm surprised that only 79% of y'all got that right. The second question was calcium pyrophosphate deposition, and the way that you'll remember that on the test is CPPD or pseudogout usually has just calcified crystals inside the cartilage. It doesn't really dissolve bone, whereas gouty tophi do dissolve bone from time to time. We're going to move a little bit to osteopenia and osteoporosis. Genetic polymorphisms in all of the following genes are associated with osteoporosis except, well, polymorphism is a little bit big word for an old bone doctor like me, and it's the occurrence of several phenotypic forms associated with alleles of one gene or homologs of one chromosome. It's basically some sort of genetic screw-up that's not working right. And so they're asking which genes can cause osteoporosis except, well, as Pat already talked about, calcitonin keeps the bone in. So calcitonin keeps the bone in. Remember that, and that'll help you think out some of these questions. Osteoclasts have receptors to both rankle and calcitonin. Rankle stimulates osteoclasts to eat bone, so rankle makes bone go away unless there's osteoprotectoring around, and calcitonin inhibits the osteoclast. So it's actually used to treat osteoporosis. And then you all know that osteoclasts are blocked by biphosphonates, and that's how they work. Estrogen, we know estrogen's good because when menopause comes, all the ladies break their hips. So estrogen prevents bone loss by favoring the balance to inhibit bone resorption. We know vitamin D is important because we treat rickets with vitamin D, and when it's not present, it's a problem, and they get weak bones. We also learned that collagen type 1 is found in bone, and it's needed for the formation of good bone as well. People with osteogenesis imperfecta have weak bones. So here's the picture of a blue sclera person. If they ever showed you that, you should jump on osteogenesis imperfecta. It's an autosomal dominant trait because it codes for a structural gene, type 1 collagen. Brittle bone disease, osteopenia, the blue sclera because the sclera has collagen type 1 as well. And the other test question that goes along with osteogenesis imperfecta is a pediatric olecranon avulsion fracture. And of course we treat it with biphosphonates. So the test question we're getting back, and we're looking for all of the genes that can screw up the bones to give you osteoporosis except, and if you look at the answers, calcitonin keeps the bone in, estrogen is good because menopause is bad, vitamin D helps absorb calcium, which is a good thing, and you got to have type 1 collagen in your bone. And so what the heck is comp? Well, comp's the answer, and that's why only 74% of people got it right. Let's talk a little bit about cartilage oligomeric matrix protein, because that's sort of a difficult question, and they could throw you some curveballs on that question. That question really falls into the category of what genes go wrong to create skeletal dysplasia. And this is a real busy slide, but I do want to say that the most common skeletal dysplasia, the most common cause of a little person, is achondroplasia, which is fibroblastic growth factor a gene problem. COMP, cartilage oligomatrix protein, causes pseudoachondroplasia, which involves the spine, but there's also a version of multiple epiphyseal dysplasia, which doesn't involve the spine at all. There's a host of diseases that collagen disorders can cause, and the most important one is osteogenesis imperfecta, which we've already talked about. So this is an example of a patient who has a cartilage oligomeric matrix protein problem. It's a structural type of gene, and so it's autosomal dominant. They usually develop normally until about 2, but then they develop a short-limbed dwarfism with a normal face, but they have problems in their spine, both their cervical spine and lordosis. They also get goofy-looking legs where they're bow-legged or windswept knees. And another interesting thing that they could throw on the test to find out that upper 1.5% are these fingerprint rough endoplasmic reticulum by electron micrograph. You can see those are kind of fancy-looking rough RER. The other cartilage oligomeric protein problem is multiple epiphyseal dysplasia. It's also autosomal dominant. It also has a goofy-looking rough endoplasmic reticulum, the slide on the upper right, but the name tells you that they have multiple abnormal epiphysis. So they have goofy knees and goofy hips. They're usually short and they waddle and they get early osteoarthritis. It's multiple epiphyseal dysplasia, so remember there's a version that's caused by cartilage oligomeric protein and another version that's caused by collagen type 9. So if they were to choose to show you a question with a funny looking rough endoplasmic reticulum electron micrograph picture, you know it's going to be a cartilage oligomeric protein disorder. And so that may be the end of the question. But if they really wanted to sort the wheat from the chaff, they could ask you, is there any spine involvement? And so you have to think about it. If the answer is yes, there's spine involvement, then that's pseudoachondroplasia. If there's not, then it is probably multiple epiphyseal dysplasia. Just remember, in most orthopedics, you go to Club Med to get away from the spine, so there's no spine at Club MED, multiple epiphyseal dysplasia. No spine there. All right. A 55-year-old healthy female presents for a routine physical exam. In regards to bone health and osteoporosis prevention, what dose of calcium and vitamin D should be recommended for daily consumption? And they gave a host of different numbers, and you can see that there's 2 of them that have 1,000 units of international vitamin D, and so that should be a clue for you. The other ones have some mega doses, and although recently there's been some news article that says just a regular dose isn't going to be enough, the board won't have that question for you. So if you look at the guidelines, women over the age of 50 need 1,200 milligrams of calcium and 800 to 1,000 international units of vitamin D every day. If you go to the NIH Offices of Dietary Supplement, they support the same recommendations for the calcium and have a little bit different recommendation for vitamin D, but that may change in the future. Thankfully, almost 90% of y'all got that right, and we'll move on. Biphosphonates help control the bone, and so they're thrown into this pile too. Long-term biphosphonate usage has been shown to cause an increase of stress reaction leading to fracture at which of the following areas? Now they're asking for a complication, but they're asking for a specific fracture complication. So when we look at biphosphonates, we know that they work by inhibiting the osteoclast, and they also interfere with the normal bone healing and remodeling. And there are case reports and sporadic cases of jaw osteonecrosis, and so that's a real thing. But the one that orthopedic surgeons are seeing more and more commonly are the atypical subtrochanteric and femoral stress fractures. So the answer, and almost all of y'all got it right, which is amazing because when I was a resident, we didn't even hear about these things. 96%. Way to go, guys. What is the primary mode of biphosphonate excretion? And so they're trying to say, where is it processed? Where's it going to go? The indications for biphosphonates are osteoporosis, metabolic bone disease, multiple myeloma, Paget's disease, polyostotic fibrous dysplasia, total joint arthroplasty to prevent osteolysis. It may help. Early stages of avascular necrosis and osteogenesis imperfecta. And there's a picture of bean here because you shouldn't use it in patients who have severe renal disease because that's the primary mode of excretion. And about 90% of y'all got that one right too, so that's great. A good second guess would be liver, but let's remember those beans for biphosphonates. We're going to go to inheritance patterns, and the question reads, a 46-year-old female begins to have personality changes, cognitive decline, and chorea. Her father began having similar but less severe symptoms at age 55 when he was older, before passing away 6 years later. One of her two older siblings has also begun to show deterioration. Which of the following describes the hereditary pattern of this disease? You got to ask yourself, is this orthopedics? That doesn't sound like orthopedics at all, but it turns out to be a genetic question, and so they want to know, does that sound like it's autosomal dominant, recessive, is it X-linked? And then some other words that you need to know about. Well, they're describing Huntington's disease, and that's caused by a triplet repeat expansion of the IT15 gene, also known as Huntington or HD, and it accounts for 90% of the chorea of genetic etiology. That part's not the orthopedics. The stuff they want to know about is the inheritance. And so in orthopedics, the ones that are autosomal dominant usually have to do with structural protein deficits. So if you see a question and you know the disease and you know it's a structural protein deficit, think autosomal dominant. And the picture on the right shows you what dominant means. The dad's affected, and 2 out of the 4 kids are affected. So there's a high likelihood of the kids getting it. The genes are associated with this, and in the recorded version you can go through it. But just remember, collagen's a structural gene. Fibrillin and Marfan's disease is a structural disease, or structural gene. Achondroplasia is caused by fibroblastic growth factor. That's a structural gene. So if it's a structural protein gene, it's autosomal dominant. If it's an enzymatic gene problem, then it's probably going to be an autosomal recessive. There's a disease called dystrophic dysplasia, which is an enzyme that transports sulfate so that you can get it into your cartilage. That's recessive. All of the ACEs are recessive. All of the mucopolysaccharidosis, Hurlers, Sanfilippo's, Morchios, those sugars that the lysosome storage issue is, those are all recessive because they're enzymes. The only exception to autosomal recessive is Hunter's. And you remember that men are hunters, and so men get X-linked recessive disorders like hemophilia and Hunter's, but it's still recessive. Gaucher's disease is probably the most common storage problem. It's also an enzyme, so it's autosomal recessive. Osteopetrosis, one version of it hits carbonic anhydrase, so it's recessive, and then homocystinuria. So we get back to the question, and the question was, all right, this lady got the disease earlier than her dad did. What's the answer? The answer is 4, and this is a little bit tougher question because there's 3 answers that are autosomal dominant, and most of y'all figured out if that 2 of the 3 kids had it, it's probably dominant. and autosomal dominant makes the most sense since she's a girl, you need to know what the word genetic anticipation is and genetic imprinting. Anticipation is when the disease develops earlier in the life for each successive generation, and that's what the answer is, anticipation number 4. Imprinting, as an aside, is a single working copy of the gene is inherited. Non-working or silenced genes is usually methylated, and the only orthopedic, even close to orthopedic example I could come up with imprinting is Prader-Willis syndrome, which is the most common genetic cause of obesity. So, basic science is the fertilizer for a successful practice. I hope you enjoyed my part of the top. It shows you the difference between shit and Shilota. I hope that this talk helped you polish up for the boards. And please don't hesitate to send any comments to Orthobullets or to me to let us know how we can improve this for you guys or your partners in the future. I'm going to turn my mic off and let you go.